Hey everyone, it's Ed again. I'm back. For those new to the channel, I'm a registered nurse, CMSRN and PCCN certified, and I love breaking down complex clinical concepts into simple, bite-sized learning you can actually remember. Today we're diving into something every nurse and clinician eventually faces: what to do when the usual treatment protocols just doesn't work. Whether you're prepping for your NCLEX or reviewing for your CMSRN, MEDSURG-BC and PCCN certifications, or you're already on the floor, medical, surgical, and progressive care units, this topic is gold because real life doesn't always follow the protocols. Sometimes the patient's condition, vitals, or other factors make standard interventions unsafe, and that's when you reach out for what I call Plan B interventions. Let's break down real cases where we had to think outside the box, clear, simple, and clinical. Let's jump right in. Refractory ventricular fibrillation. When the heart quivers instead of pumping, there's no blood, no pulse, no perfusion. Usually, we start with a high-quality CPR and a single Defib shock to reset the heart rhythm. But when that doesn't work, we can actually use the Dual-Sequential Defib or DSD. Two shocks delivered almost simultaneously from different angles. The science here is that by shocking the heart along multiple vectors, we increase the chances that all the cardiac cells depolarize at once, hopefully letting the heart restart in an organized rhythm. However, there is a caveat in the use of DSD. It is not yet part of the universal ACLS standard. Evidence is promising, okay, but still very limited, and it's only used in some EMS and hospital systems for refractory VF. The standard of care continues to be your usual Defib and a high quality CPR. Next up is your bradycardia unresponsive to atropine. This is when the heart rate is abnormally and persistently slow and the patient is asymptomatic. Normally we give atropine, which blocks the vagus nerve's parasympathetic effect on the heart, allowing the heart rate to rise. If the heart still doesn't respond, we move to pacing, either transcutaneous or transvenous. Transcutaneous pacing uses external pads placed on the chest and back. It's quick, non-invasive, and life-saving in emergencies, but it could be very uncomfortable and temporary. On the other hand, transvenous pacing involves placing a catheter or pacing wires through a central vein directly into the right ventricle. It's more invasive but provides consistent long-term pacing with better control and synchronization. And just to add one more, if pacing isn't available right away, we can start dopamine or epinephrine infusion as a bridge. These drugs stimulate beta-1 receptors to increase heart rate, contractility, and conduction, while epinephrine also boosts vascular tone through alpha effects, helping to keep blood pressure up. So the science here is that when atropine fails, pacing and a vasoconstrictive infusion keep perfusion going by bypassing or compensating for the failing conduction system, basically letting the machine or medication take over the rhythm temporarily. Next up is your atrial fibrillation with persistently low blood pressure. So here, the heart beats fast and irregular, but the blood pressure is low. Usually we give beta blockers or calcium channel blockers to slow it down, but this can drop the blood pressure even more. So instead, we go for a synchronized electrical cardioversion, delivering a controlled shock to reset the rhythm. The science in here is that the shock depolarizes all cardiac cells simultaneously, letting the SA node, the heart's natural pacemaker, take back control. The SA node, or sinoatrial node, located in the right atrium, gets the pace for the entire heart at about 60 to 100 beats per minute, initiating each heartbeat. Cardioversion is time with the R wave, the tall spike on the ECG representing ventricular depolarization or your ventricular contraction. We avoid shocking on the T wave, which represent ventricular repolarization, the heart's electrical reset phase. If we shock during this phase, known as the R on T phenomenon, it can trigger life-threatening arrhythmias like V A-Fib or your ventricular fibrillation. That's why synchronization matters. It's like rebooting your Wi-Fi safely and on cue. Now, I want to talk about pulmonary embolism when anticoagulation therapy is unsafe. A blood clot gets lodged in the lungs, blocking blood flow. Normally, we use heparin or anticoagulants to prevent new clots. But if the patient is actively bleeding or at high bleeding risk, we place an IVC filter instead. The science in here is that the IVC or inferior vena cava filter is ideally positioned below the renal veins, and that's intentional. Placing it below the renal veins protects the kidney's venous drainage, ensuring any trapped emboli don't obstruct the renal veins and allowing filtered blood from the kidneys to continue draining freely into the IVC. It acts as a mechanical barrier, catching clots traveling up the legs, or we call it deep vein thrombosis, before they can reach and block the pulmonary arteries. Think of it as a tiny metal in your bloodstream protecting the lungs when blood thinners can't be used. This one I don't often encounter, your high ICP or intracranial pressure not responding to diuretics or mannitol. When mannitol isn't enough, we use hypertonic saline, a concentrated salt solution. So think of it as your normal saline above 1% tonicity. For this scenario, the science behind it is all tied up with your osmosis, where water moves from area of lower solute concentration to areas of higher solute concentration across a semi-permeable membrane. So when hypertonic saline is infused into the bloodstream, it creates an osmotic gradient that draws water out of a swollen brain tissue and into the blood vessels, reducing cerebral edema. It also helps expand plasma volume, maintaining cerebral perfusion pressure, or your CPP, so oxygen still reaches the brain. Basically, it dries the brain gently while improving blood flow, a perfect osmotic balancing act. Let's throw in here stroke without thrombolysis. When a blood clot blocks an artery in the brain, we usually give tPA, or the tissue plasminogen activator, but only within 4.5 hours of symptoms onset. Why the time limit? Because tPA breaks down clots by converting plasminogen to plasmin, which dissolves fibrin in the clot. However, as time passes, the brain tissue beyond the blockage becomes irreversibly damaged and fragile. After 4.5 hours, the risk of intracranial bleeding outweighs the potential benefit of restoring blood flow. If tPA is impossible or doesn't work, we go to mechanical thrombectomy, aka physically retrieving the clot via a catheter. The science in here is that thrombectomy restores blood flow immediately, especially in large vessel occlusions, and can be done up to 24 hours after onset if imaging shows viable tissue. Severe traumatic brain injury with brain swelling. When osmotic therapy isn't enough, we may need a decompression craniectomy. It is surgically removing part of the skull to let the swollen brain expand outwards. So the science in here is that this procedure or surgery prevents catastrophic increases in intracranial pressure and herniation, which can compress the brainstem and stop breathing. The bone flap is then saved and replaced later on once swelling resolves. This one is your favorite, severe hyperkalemia. So high potassium can throw the heart into lethal arrhythmias. We lower potassium with insulin, albuterol, diuretics, binding resins, but first, we can give calcium gluconate to stabilize the heart. You may be familiar with most of these potassium-lowering agents, but do you know why albuterol is on the list? Well, albuterol lowers serum potassium by driving it into cells via the sodium and potassium pump. The science in here is that calcium gluconate doesn't necessarily lower your potassium. It stabilizes the cardiac membranes, raising the threshold for depolarization so the heart doesn't fibrillate while we fix the underlying potassium imbalance. Second to the last are severe acidosis. When blood is too acidic, we correct the underlying problem. But if the pH drops dangerously low, let's say below 7.1, we may use bicarbonate infusion to temporarily buffer the acid. The science behind this is that bicarbonate soaks up extra acid in the blood, turning it into water and carbon dioxide. This raises the blood pH, helping the heart work safely and acts as a temporary fix while doctors and nurses to treat the main problem causing the acid buildup. And last would be our acute kidney injury with fluid overload. So when kidneys can't clear waste or fluids, we try diuretic first. If that fails, we move on to the next, which is your hemodialysis. The science in here is that dialysis mechanically filters blood to remove waste. You already know this. And that's a wrap, nurses. We've covered a lot today, from cardiac emergencies to neuro and renal rescue strategies, all those plan B interventions that saves lives when the usual approach isn't just enough. If you found this video helpful, hit that like button, share it with your coworkers, and make sure you subscribe to my channel because there's plenty more clinical breakdowns coming your way. Whether you're gearing up for your NCLEX, advancing to your CMSRN, RN-BC, or PCCN credentials, or fine-tuning your skills in the medical, surgical, and progressive care units, this channel is here to make complex clinical concepts easy to understand, practical, and fun. This is Ed signing off. Stay curious, stay confident, and as always, keep thinking outside the box. See you again next week.